To the location of the ostomy, the ostomies in the descending colon had more complication rate compared to the transverse and sigmoid colon. You can see the all complication distribution of the all complications, and prolapse was seen mainly in the loop ostomies, and the wound problems, I mean ulceration, vestigial hernia, and some wound lesions were seen in the separated ostomies, and most of them were with mucous fistula. And you see the general complication rates in the series, and mostly prolapse and stenosis and problems. And three ostomies of 24 cases were performed in a training center, 14 by us, 10 by the others. And unfortunately, 12 of 24 patients had to be operated again because of ostomy complications, and 2 babies were lost because of ostomy complications related to ostomy, and both of them had separated ostomy. And we inspected our separated ostomy, and 8 of them had mucous fistula, and they had more complication rate compared to those without mucous fistula. And you see ideal separated descending colostomy described by Dr. Beya, but we had to do a small modification to protect ostomy complications related to wound problems. And before the operation, the future ostomy area was marked, and then the proximal colon was taken out from this area around untouched skin, you see, and you can see the mucous fistula below. And after this modification, we didn't see any wound problems, and were able to discharge the patients earlier. And we could achieve only in 112 patients about ostomy closure, and 12 of them had complications related to ostomy closure, especially wound infection and intestinal obstruction. So, according to our results, ostomy performed in the descending colon carries greater risk for complication regardless of ostomy type. Nevertheless, in learning curve, separated ostomy with mucous fistula should be performed by experienced hands. Thank you for your attention.
Well, thank you. The paper is open for discussion. Any questions or comments?
Sorry that I come in so much, but I cannot resist the temptation. The colostomy is the importance of your paper, Bilur, is that you are emphasizing the fact that colostomy is a procedure with high morbidity, and that this should not be underestimated in the technical complexity of a good colostomy. The idea of opening a colostomy in 30 minutes in a loop in a hole in the abdomen in the middle of the night in an emergency room in a general hospital doesn't belong to pediatric surgery. Pediatric surgery colostomies are delicate procedures and require a meticulous technique. Now, your paper could convey the message that it's better to do a transverse colostomy rather than descending colostomy. That's what you concluded in your paper. However, let me tell you a few of the disadvantages that we have seen of over 1,000 cases that came to us already with a colostomy, because most of the patients that we operate already have a colostomy done in other institutions all over the world. And we have seen all kinds of complications of that we published already. Transverse colostomies is very difficult to clean the distal colon from a transverse colostomy, and therefore the patient have this accumulation of meconium in the distal part. And if you open a transverse colostomy, the colon continues having peristalsis and pushes mucus distally. Mucus and epithelial cells from the mucosal cells, that go and accumulate in the distal part of the bowel. That promotes frequently urinary tract infections. In addition, if you open a transverse colostomy and you wait a long period of time, the more you wait, the more megarectomy the patient develops and at the time of the operation. And there's a direct correlation between the degree of megarectum and the degree of constipation that the patient will have post-op. The complications that occur in performing high-pressure distal colostogram occur much more frequently when the patient has a transverse colostomy, because it's very difficult for the radiologist to inject with enough pressure through the transverse colon in order to force the contrast material to pass through a minor fistula. And we know from our point of view, the high-pressure distal colostogram is the most valuable diagnostic test, and a patient should never be operated without having this study done prior to this. So, and when the surgeon tries, it's very difficult to do a good distal colostogram. When the patients have a recto-urinary fistula, they pass meconium from the rectum to the urinary tract, but also pass sometimes urine back to the bowel. When the patient have a descending colostomy, the urine comes out through the mucous fistula. When the patient have a transverse colon, the urine sits there and produces hyperchloremic acidosis. All those we consider in anorectal malformation a bad procedure at transverse colostomy. The complications that you mentioned are certain technical details. What they demonstrate is that the people who was doing these descending colostomies had no experience with a good descending colostomy. Not necessarily that the transverse is better, considering the anorectal malformations. I enjoy your paper review.
Thank you, Dr. Lina, for the explanation. I didn't know the results I found like this, but I think we have a training center, working training center. I think because of this, we found this complication rate, high complication in the descending colon. And of course, in the future, we will develop our techniques and for great ostomies, especially because of fistula.
I have one question, because I was impressed about the number when you said separated stomas but no mucous fistula. That means a Hartmann pouch. That means it was closed, the distal portion.
Yes, some which no. Just one ostomy here, one ostomy proximal up, and this side below. No Hartmann pouch. No Hartmann pouch. Separated, with two ostomies.
And just I saw that you had one perforation during the distal colostogram. This is a very rare complication, but when it happens, it's very serious. So I wonder, how did your patient do? Was the patient okay after the perforation?
This was a very interesting patient. The patient was with Down syndrome, and the ostomy, sigmoid ostomy, but in the right upper quadrant. And the resident went to go to the radiology department by himself, and when he was doing the distal colostogram and Down syndrome with connective tissue, and therefore perforation during the distal colostogram, and then he was operated emergent immediately, and it was a very old case, very old case. Now the child is very good after operation, and the child is very good, the patient, and he's under the follow with laxative treatment and with bowel movements. He's okay, no more.
Because in theory, we think that if the patient is already diverted and there is a perforation, in theory, we would not have to operate. But those patients, they get sick very fast, They sequestrate a lot of liquid, and we have to operate them, we have to repair the perforation, sometimes there is bleeding, and usually they require intensive care unit. I hope it never happens, but if it happens with you, watch out for these patients, they get very sick.
Okay. Thank you very much for your presentation.
Thank you.